This is your musculoskeletal system supplemental lecture. So let's start with our anatomical terminology. Again, doesn't matter what system it is. If you start with your basic anatomy and physiology, you will do just fine. So let's start with articular structures. These are structures that include the joint capsule and articular cartilage, the synovium and synovial fluid, intra-articular ligaments, and juxta-articular bone. We know that articular cartilage is comprised of a collagen matrix that contains charged ions and water, which allows the cartilage to change shape in response to its environment, so to pressure or to load, and that also acts as a cushion for the underlying bone. The synovial fluid provides nutrition to the adjacent relatively avascular articular cartilage. So in terms of articular structures, we know that articular diseases will typically involve swelling and tenderness of the entire joint and will limit both active and passive range of motion due to either stiffness or to pain, or sometimes both. With extra-articular structures, these include periarticular ligaments, tendons, bursa, the muscle, fascia, bone, nerve, and the overlying skin. So extra-articular diseases will typically involve selected regions of the joint and types of movement. So we know that ligaments connect bone to bone, tendons connect muscle to bone. The cartilage we just mentioned, and the bursa are pouches of synovial fluid that cushion the movement of tendons and muscles over bone or other joint structures. When it comes to synovial joints, these are the bones that do not touch each other. So if you're looking on an x-ray, for example, this would be helpful. And the joint articulations are freely movable, that's the key there. Within that, the limits the surrounding of the ligaments. So the bones are covered by articular cartilage and then separated by the synovial cavity that cushions the joint movement. Then we know that the synovial membrane lines that synovial cavity and secretes a small amount of this viscous lubricating fluid that we call synovial fluid. Kind of all works together. It makes sense, especially with the term. The membrane is attached at the margins of the articular cartilage and pouched or folded to accommodate joint movement. Surrounding the joint is a fibrous joint capsule, which is strengthened by ligaments that extend, again, bone to bone. So some examples of this is your shoulder or your knee. Moving on to the cartilaginous joints, in comparison to the synovial joints, cartilaginous joints are slightly movable. So these are bones that are separated by the fibrocartilaginous discs. So for example, in the vertebra, and these discs in between, and your picture, the diagram here on the screen shows exactly what I'm talking about here, that the discs act as a cushion in between the two vertebrae, for example, and allow for that movement. Think of it almost as a shock absorber between the two bony surfaces. A fibrous joint, and these joints, such as the sutures of the skull, intervening layers of fibrous tissue or cartilage, will hold the bones together. The bones are almost in direct contact, as you see here in the picture, which allows no appreciable movement. So to kind of break those down, synovial joints, free moving; cartilaginous joints, slightly movable; and fibrous joints, there's no true movement. So going over the different types of synovial joints, you have your spheroidal, or we know as in layman's terms, I guess, your ball and socket, and then your hinge and condylar. So if you know the type of joint, the articular shape, what type of movement you get with it, and then of course an example, you should be able to know the differences each time. So moving on to the health history, some common or concerning symptoms, especially as you do your review of systems. If a patient complains of low back pain, neck pain, monoarticular or polyarticular joint pain, any inflammatory or infectious type of joint pain, Joint pain with systemic features that might have fever, chills, rash, lack of appetite or anorexia, weight loss and weakness, and then joint pain with symptoms from other organ systems. So if a patient comes in complaining of joint pain, we know that joint pain is one of the leading complaints of patients that are seeking health care. So in addition to obtaining the 7 features of any joint pain, you want to adopt 3 tips to help your exam and then subsequently your diagnosis. So you want to always ask the patient to point to the pain. So this can help save you quite a bit of time, and just like I've mentioned in other lectures before, I always have the patient point to their pain with one finger. This way it allows me to understand exactly the spot of where they're having their pain. So for example, if they're having elbow pain, well, is it medial or is it lateral? And that can be a complete difference on the potential structural issues. You always want to clarify and record when the pain started and any mechanism of injury. So this tells me if there's any trauma or is it something that they woke up with, for example. And you also want to determine whether the pain is localized or diffuse, acute or chronic, or inflammatory or non-inflammatory. So you always want to inspect the joint for symmetry, alignment, or if there's any obvious gross bony deformities. So you want to inspect and palpate the surrounding tissues to see if there's any skin changes. This might also help to tell you if there's infectious or inflammatory issue. If there's any nodules or muscle atrophy or any crepitus. Always want to assess any degenerative or inflammatory changes, especially if the patient complains of any swelling, or as if you're doing your exam, if you feel it's warm to touch, if the patient complains of any tenderness, or if there's any redness associated. Always want to perform range of motion, and of course use the joint-specific maneuvers to test. So again, is it ball and socket? Is it hinge? Example. So always checking the joint for its function and stability. You want to always look for the integrity of ligaments, tendons, and the bursa. So then when you go to each area of the musculoskeletal system, again, it's always important to know the anatomy, so you know which ones, what bones you're checking for. So for example, in doing a shoulder exam, so you're always wanting to observe the shoulder and the shoulder girdle itself anteriorly, and then inspect the scapula and related muscles posteriorly. Here, so for example, scoliosis may cause an elevation in one shoulder. So with an anterior dislocation of the shoulder, the rounded lateral aspect of the shoulder will appear flattened. So again, why it's important to look at both sides. You want to note any swelling, deformity, muscle atrophy, any fine tremors of the muscle, or any abnormal positioning. So when it comes to, say, atrophy of the supraspinatus and infraspinatus with increased prominence of the scapular spine, can appear within a couple of weeks, 2 to 3 weeks, of a rotator cuff tear. So again, obviously getting a good history on when the patient's symptoms started. So you're looking for swelling of the joint capsule anteriorly, or for a bulge in the subacromial bursa just under the deltoid muscle. So by surveying the entire upper extremity for any color changes, skin alteration, or any unusual bony contours, because a significant amount of synovial fluid is needed before the glenohumeral joint capsules appear distended. So swelling of the AC joint is easier to identify since it's more superficial. Then moving on to palpation, you want to palpate over the bony structures of the shoulder, and then palpate any area of pain. By beginning medially, so you'll start at the sternoclavicular joint and then trace the clavicle laterally with your fingers. Again, this is especially important if you have a patient that has a larger body morphology. So then from behind, you want to follow the bony spine of the scapula laterally and upward until it becomes the acromion. And there's, again, this is covered in your book in specific detail. Then you want to do range of motion. So flexion, extension, abduction, adduction, internal and external rotation. Because again, this is checking the range of motion and the ability to see what's going on from the tendon ligament aspect as well. Now, the question you would want to ask yourself is, is maybe a decrease in range of motion due to pain, or is it due to swelling, or multiple things? But the idea is you want to know kind of to the degree in which, say, a patient can extend their arm, or how far they can abduct or adduct, because of course there's going to be principal muscles that will be affected during this movement. So again, assessing the AC joint, the subacromial and subdeltoid bursa, overall shoulder rotation. So for example, the Apley scratch test, which you would have learned in immersion. And of course, checking for any rotator cuff type of tear. So here's a question. A patient presents to you with shoulder pain after falling during an ice storm. On examination, he exhibits localized shoulder pain when you perform the crossover test. And this is where you cross the arm over to the opposite side of the chest while extending at the elbow. So which of the following is most likely the site of injury? Rotator cuff, bicipital tendon, glenohumeral joint, or AC joint? And if you answered the AC joint, you would be correct, because localized tenderness or pain with adduction suggests inflammation of the AC joint. Then moving on to the wrist and the hand, looking over the anatomy, because it's important that we know that the wrist and the hand involves a complex of very small and highly active joints that are used throughout the day. Very little protection from any overlying soft tissue, which also increases its vulnerability to any trauma and disability. When you start to inspect the wrist and the hand, you're looking for a smoothness of the motion, the surface contour, alignment of the wrist and the fingers, and any obvious bony deformities. So you always know that, for example, the wrist, or excuse me, with the hand just at rest, the finger should be slightly flexed, and we know that's due to the ligaments. Moving on with palpation, it's important that starting with the wrist, you want to palpate the distal radius and the ulna on the lateral and medial surfaces. And then you, of course, palpate the groove of each wrist joint with your thumbs, and then you want to have your thumbs on the dorsum and then your fingers below it. Here you're noting any swelling or bogginess or tenderness. So for example, if you have tenderness over the distal radius, you might have a Colles fracture from a fall, so especially more prominent in patients with osteoarthritis, or excuse me, osteoporosis. Any tenderness or bony step-offs might be suspicious of a fracture. If you have swelling or tenderness, that might suggest rheumatoid arthritis if it's been there bilaterally for a few weeks. Then you also want to palpate the anatomic snuff box. So here you're palpating the radial styloid and that hollow depression that's just distal to the radial styloid process, which is formed by the abductor and extensor muscles of the thumb. Then when you abduct the thumb away from the hand, that little hollow depression there can be more visible. So why is that important to know? For example, if there's tenderness over the extensor and abductor tendons of the thumb, then that might suggest de Quervain's tenosynovitis or even gonococcal tenosynovitis. If there's tenderness over that snuff box area, that would suggest a scaphoid fracture. And that's again most vascular, most common in terms of carpal injuries. So, and then we know that, of course, poor blood supply puts the scaphoid bone at risk for avascular necrosis. Then you want to check range of motion of the wrist, the fingers, and the thumb. You want to test for hand grip strength, and it's important that you do that bilaterally so you can be able to tell the differences bilaterally to see if there's any decrease in strength. So we know that if there's a decreased grip strength, that's a positive test for weakness of the finger flexors and or the intrinsic muscles of the hand. This may also result from pain from degenerative joint changes. You want to test sensation on the palmar and dorsal surfaces by the median, ulnar, and radial nerves. So another common one is carpal tunnel syndrome. So patient will present with pain or numbness in the first 3 fingers of the hand, so the thumb, the index, and the third finger, but not in the palm, and this is especially at night. They might have a loss of sensation in distribution of that medial nerve, so which is the palmar surface of the thumb, index, middle, and medial fourth finger. So in order to assess if it's carpal tunnel syndrome or not, if they have weak abduction of the thumb, then that's one of the most sensitive tests to be able to see if the patient has carpal tunnel syndrome. You can do Tennille's sign for median nerve compression by tapping lightly over the course of the median nerve in the carpal tunnel. And there's a diagram in your book. So any aching or numbness in this median nerve would be considered a positive test. Fallon's sign for median nerve compression by asking the patient to hold the wrist in flexion for 60 seconds. So what you do is have the patient put the dorsal part of their hand back to back and then hold that for 60 seconds. So any numbness or tingling in the median nerve within the 60 seconds is considered a positive test. So Tennille's and Fallon's sign do not reliably predict positive electrodiagnosis of carpal tunnel syndrome. Just keep that in mind. So here's a question. If a patient who presents to the clinic complaining of hand pain says she was told by a friend that it's most likely carpal tunnel syndrome, upon assessing the patient, you note that the following findings, which would be suggestive of carpal tunnel syndrome: hand pain when holding both hands in acute extension, numbness and tingling when tapping over the course of the radial nerve, symptoms related to compression are evident in all of the fingers, or none of the above. And we know that it's none of the above because symptoms of carpal tunnel syndrome include numbness or tingling with pressing the backs of the hands together in acute flexion for 60 seconds. There's tingling with tapping over the median nerve, not the radial nerve, median nerve as it enters the carpal tunnel. And then there's pain or numbness in the first 3 fingers of the hand, but not in the palm itself. Moving on to the vertebra, so the vertebral column, or the spine, is the central supporting structure of the trunk and back. The concave curves of the cervical and lumbar spine and the convex curves of the thoracic and sacrococcygeal spine help distribute upper body weight to the pelvis and lower extremities, and that also helps to cushion the concussive impact when you're walking or when you're running. So when you're doing a quick overview, of course, we have 7 cervical vertebra, 12 thoracic, and 5 lumbar, and these are all stacked on each other, and then the sacrum and the coccyx are fused. So a good way to remember this, if you have trouble with this, is there 7 cervical, 12 thoracic, and 5 lumbar. So for example, you're going to eat breakfast at 7 a.m., you're going to eat lunch at 12 noon, and then you're going to have dinner at 5 p.m. The vertebral column contains 24 vertebrae that are stacked on top of each other, like we mentioned. It's important to know all the bony structures. So, for example, the spinous process, which projects posteriorly in the midline, and then the 2 transverse processes at the junction of the pedicle and lamina, and muscles will attach to these processes. The articular process, these are 2 on each side of the vertebra. One faces up and the other faces down, and this is at the junction of the pedicles and lamina. A lot of times you'll hear this as articular facets. And then the vertebral foramen, and we know that encloses the spinal cord, and the intravertebral foramen, which formed by the inferior and superior articulating processes of the adjacent vertebra, which creates a channel for the spinal nerve roots, and in the cervical vertebrae, the transverse foramen of the vertebral artery. Moving on to the muscle groups, we know that the trapezius and latissimus dorsi, from the large outer layer of muscles attached to each side of the spine. Then they overlie two deeper muscle layers, a layer attaching to the head, neck, and spinous process, and then a layer of a smaller intrinsic muscle groups between the vertebra. So muscles attaching to the anterior surface of the vertebra, including the psoas muscles, and muscles of the abdominal wall assist with flexion. So going back to the abdomen lecture, you know that the psoas muscles is part of our assessment, especially when you're looking for appendicitis. So you're going to start with inspection. So you're going to start by observing the patient's posture when entering the room, and including the position of both the neck and the trunk. So you're assessing the patient for their erect position of the head, neck, and back, and for smooth, coordinated neck movements, and for ease of gait. So we know, for example, neck stiffness will signal arthritis, a muscle strain, or any other underlying pathology that should be further examined. Patient may also have a headache as well. From the side, of course, you want to look at the cervical, thoracic, and lumbar curves. Remember the convex versus concave. You kind of want to have that S shape of the spine. Then from behind, looking at the upright spinal column, you want to look at alignment of everything, looking at symmetry, of course, of the shoulders, iliac crest, and gluteal folds. And of course, while you're back there, make sure you can do a skin inspection, looking at any skin markings, tags, or masses. Then you want to palpate. So from a sitting or standing position, palpate the spinous processes of each vertebra with your thumb. So you start at the top with the cervical and move all the way down. And this is especially important if you suspect any type of traumatic mechanism of injury, for example. But here you can also rule out a lot as well. Is it from the spinal processes, for example, or is it more muscular? You want to also assess the facets joints in the neck, and then the lower lumbar area for any vertebral step-offs or tenderness. So here you can also percuss the spine for any tenderness by doing not too rough of a percussion with the ulnar surface of your wrist. So any pain on percussion, for example, might arise from osteoporosis, infection, or even potentially malignancy. Then, of course, you want to move on to the paravertebral muscles for any tenderness or spasms. And you do want to make sure that you also assess and palpate the sacroiliac joints. When you're doing range of motion, you want to do flexion and extension. So this is asking the patient to bring their chin down to their chest and then looking up at the ceiling. You can have, you're checking for rotation. This is where you can have the patient look over one shoulder and then the other. And then with the spine, flexion and extension by asking the patient to bend forward and trying to touch their toes. Here you want to assess the smoothness and symmetry of the movement, of course the range of motion, and also the curve of the lumbar area. Because we know that flexion precedes the lumbar concavity should then flatten out. So any persistence of lumbar lordosis would be suggestive of any muscle spasm, for example. Then you want to check for rotation and lateral bending. This is having them rotate at the trunk, so basically pulling their shoulder and then opposite side hip posteriorly. So rotate from side to side. Then you can have them, again, rotation and lateral bending. Then the hip joint we know is deeply embedded in the pelvis and is notable for its strength, stability, and wide range of motion. The stability of the hip joint, essentially for weight bearing, will arise from deep fit of the head of the femur into the acetabulum and its strong fibrous articular capsule and the powerful muscles crossing the joint and inserting below the femoral head, providing leverage for movement of the femur. So we know that it's a ball and socket joint. You want to note how the rounded head of the femur articulates with a cup-like cavity at the acetabulum. So from an anterior surface of the hip, you want to be able to locate the iliac crest, and that'll be at the level of approximately L4, the iliac tubercle, the anterior superior iliac spine, the greater trochanter, and the pubic tubercle. Again, keeping in mind, depending on body morphology, this might be difficult. Posteriorly, you want to check for the posterior iliac spine, the greater trochanter, the ischial tuberosity, and the sacroiliac joint. So if you kind of think of a imaginary line between the posterior superior iliac spines, crosses over at approximately S2. When you're inspecting, there's two phases of gait. So the swing, so looking at how the foot moves forward, any non-weight bearing and stance, looking at the foot on the ground and weight bearing. Then you're looking at, or you're assessing the width of the base. So 2 to 4 inches heel to heel. There should be a shift of the pelvis, which should be smooth and continuous. And of course, flexion of the knee, because flexion throughout the stance phase. So you can look at the stance and swing phase. As we know, most hip problems will appear during the weight-bearing stance phase. You also want to inspect, again, anterior and posterior surfaces of the hip for any muscle atrophy or bruising. If the patient has a wider base, that would suggest a cerebellar disease or potentially even foot problems. If there's any hip dislocation, arthritis, leg length discrepancy, so one's longer than the other, or abductor weakness, that can cause the pelvis to drop on the opposite side, and that can even give them a waddling gait. Again, be able to palpate the bony landmarks and the inguinal ligament. So you're still assessing for range of motion, looking at flexion, extension, abduction, and adduction, and external and internal rotation of the hip. Moving on to the knee anatomy, we know that the knee joint itself is the largest joint in the body. It is a hinge joint that involves 3 bones, the femur, the tibia, and the patella. There's 3 articular surfaces. There's 2 between the femur and the tibia, and 1 between the femur and the patella. So the 2 condylar tibiofemoral joints are formed by the convex curves of the medial and lateral condyles of the femur as they articulate with the concave condyles of the tibia. And then the 3rd articular surface is the patellofemoral joint, and the patella sides on the groove of the anterior aspect of the distal femur, called the trochlear groove, during flexion and extension of the knee. So think about it this way. The knee is very dependent on the ligaments, which we'll talk about just momentarily, to hold it together. And then since there's not a whole lot of overlying fat or muscle, this makes the knee very vulnerable to injury. So any problems with the patellar tracking, so for example, if they have a shallower groove, more common in women, this can lead to arthritis or anterior knee pain and even patellar dislocation. So when talking about ligaments, you have the medial and lateral menisci, and these act as a cushion between the femur on the tibia. You have your medial collateral ligament, or MCL. This isn't easily palpable because it's a very broad, flat ligament that connects the medial femoral epicondyle to the medial condyle of the tibia. So if you're having trouble with trying to remember all these things, medial, MCL collateral ligament, going with the medial epicondyles. And we also know that the MCL will attach to the medial meniscus. You also have the LCL, or lateral collateral ligament, which connects the lateral femoral epicondyle to the head of the fibula. MCL and LCL will provide medial and lateral stability of the knee joint. So if you know that, then this way when we get into some of the musculoskeletal exams, you'll be able to tell if there's an issue of what ligament might be causing the problem. ACL, or the anterior cruciate ligament, crosses obliquely from the anterior medial tibia to the lateral femoral condyle, which prevents the tibia from sliding forward on the femur. It's kind of nice. Then we have the PCL, or posterior cruciate ligament, which crosses from the, you guessed it, posterior tibia and lateral meniscus to the medial femoral condyle, which prevents the tibia from slipping backward or posterior on the femur. So because these ligaments lie within the knee joint, they are not palpable. They are nonetheless crucial to the anterior-posterior stability of the knee. So moving on to inspection, you want to be able to observe the gait for a very smooth, rhythmic flow as the patient enters the room. The knee should be extended at the heel, strike, and flexed at all other phases of swing and stance. So, for example, if there's any stumbling of the knee during the heel strike, which suggests a quadricep weakness or abnormal patellar tracking. You want to check the contours and alignment of the knee for any swelling. You also want to look at the knee action during the swing and stance phases of gait. If there's any swelling over the patellar, that would suggest a prepatellar bursitis. Swelling over the tibial tubercle would suggest intrapatellar and or medial bursitis. When the patient is sitting, have them sitting on the edge of the exam table with the knees in flexion. Here you want to look at the bony landmarks, should be more visible, and the muscles, tendons, and ligaments are more relaxed, which makes them easier to palpate. So you want to pay attention to areas of any tenderness. Pain will be a common complaint in the knee problems, and localizing the structure causing the pain is important for an accurate evaluation. So looking at the infrapatellar spaces, which are adjacent to the patella, medial and lateral femoral epicondyles and condyles, the medial and lateral margins of the tibial plateau, and insertion of the patellar tendon in the tibial tubercle. A lot of words there. Then you want to move along the joint line, and this includes the menisci and the bursa, because again, if there's tenderness there, you can help figure out where there's a potential problem. Along the medial and lateral collateral ligaments, and over the patellar tendon. If we mentioned before, if there's tenderness here, you want to compress the patella against the femur and check for knee extension. So this, if there's any tenderness in these areas, this might suggest a partial or complete tear of the patellar tendon. I'm going to palpate over the suprapatellar bursa just above the knee, the prepatellar bursa, which is over the patella, and then the posterior medial knee, or the pes anserine bursa. So if there's swelling, you want to palpate for the bulge sign or balloon sign, or the ballot of the patella. Here we're looking for any signs of effusion for the knee. You want to check for all range of motion, again starting with the patient in a sitting position. You can do flexion, extension, internal and external rotation. If you have any pain or swelling with these, use maneuvers to test stability of the ligaments and the integrity of the menisci. So for the MCL, you'll do abduction or the valgus stress test, whereas at the lateral, you'll do adduction or the varus stress test. So medial is valgus, lateral is varus. Checking for the anterior cruciate ligaments, you're doing the Lockman's test or the anterior drawer sign. For PCL, you want to do the posterior drawer sign. And the medial and lateral menisci, you'll do the McMurray's test. So if it makes sense this way, in terms of knowing your anatomy and what the purpose of each ligament does, and then you check for these problems, then you'll be able to figure out which ligament or which bony part of the knee, for example, is involved. So think about it this way. We'll use ACL. It's a common injury. We know that ACL injuries will occur with hyperextension and direct blows to the knee, and with twisting or landing on an extended hip or knee. So if you have a forward jerking movement when you're doing the anterior drawer sign, that'll be considered positive with that jerking movement of the upper tibia, which then would make an ACL tear about 11.5 times more likely. You want to know the anatomy of the ankle and the foot. We know that the ankle is a hinge joint that's formed by the tibia, the fibula, and the talus. The tibia and fibula act as a mortise which stabilizes the joint while bracing the talus like an inverted cup. Principal joints of the ankle are the tibio-talar joint, which is between the tibia and the talus, and the subtalar joint. Now, you want to note that the principal landmarks of the ankle, which is the medial malleolus, which is that big bony prominence at the distal end of the tibia, and the lateral malleolus, which is the distal end of the fibula. Typically, this is what we consider the ankle. Just from a layman's term aspect, if a patient comes in saying, my ankle hurts, generally this is what they're looking at. So, of course, you want to inspect the surfaces of the ankles and feet for any deformities, nodules, any swelling, calluses, or corns. You want to palpate the anterior aspect, the Achilles tendon, the heel, medial and lateral malleolus, the metatarsophalangeal joints, and the heads of the 5 metatarsals. So if you have localized tenderness, it's often present in arthritis, any ligament injury, or infections of the ankle. Sometimes bone spurs might be present at the calcaneus or the heel. So focal heel tenderness on palpation of the plantar fasciitis would suggest plantar fasciitis. And that's usually seen in our patients that have prolonged standing or heel strike exercises, which are also in rheumatoid arthritis and gout. Any pain or tenderness can cause, again, from trauma, arthritis, or other vascular compromises. Then you want to go over the range of motion. So having the patient do plantar flexion, so point your foot towards the floor. Dorsiflexion, point your foot towards the ceiling. Inversion is having your bend your heel inward, and then eversion, bending your heel outward. Continuing on with the tibio-talar joint or the ankle, having the dorsiflex and plantar flex at the foot and the ankle. If there's any pain during the movement here, this can help localize possible arthritis. The subtalar joint, here you'll stabilize the ankle with one hand and then grasp the heel with the other. And then you want to invert and evert the foot by turning the heel inward and outward. Because an arthritic joint is frequently painful when moved in any direction, whereas a ligament sprain, for example, will produce maximal pain when the ligament is stretched. Then with the transverse tarsal joint, you want to stabilize the heel and then invert and evert the forefoot. And then with the metatarsophalangeal joint, you'll move the proximal phalanx of each toe up and down. So any pain here would suggest acute synovitis, instability occurring in chronic synovitis and claw toe deformity.